Welcome, everyone. Today, we'll be discussing the use of adrenaline in the treatment of cardiac arrest. Cardiac arrest is a medical emergency where the heart stops beating, leading to a cessation of blood flow to the brain and other vital organs. Our focus will be on the role of adrenaline, its administration, mechanisms of action, and clinical considerations. What is adrenaline? Adrenaline, also known as epinephrine, is a sympathomimetic drug. It's been a cornerstone in the management of cardiac arrest for over 40 years due to its powerful effects on the cardiovascular system. Administration of adrenaline. Adrenaline is administered differently depending on the type of cardiac rhythm, shockable or non-shockable. Shockable rhythms, ventricular fibrillation and pulseless ventricular tachycardia. Dose, 1 mg, 10 ml of 1 in 10,000 or 1 ml of 1 in 1,000, IV. When to give, after the third shock once compressions have been resumed. Frequency, repeated every 3 to 5 minutes, alternate loops. Note, administer without interrupting chest compressions. Non-shockable rhythms, pulseless electrical activity asystole. Dose, 1 mg, 10 ml of 1 in 10,000 or 1 ml of 1 in 1,000, IV. When to give, as soon as circulatory access is obtained. Frequency, repeated every 3 to 5 minutes, alternate loops. Note, administer without interrupting chest compressions. Mechanism of action. Adrenaline has dual effects that make it particularly effective during cardiac arrest. Alpha-adrenergic effects. These cause systemic vasoconstriction, increasing coronary and cerebral perfusion pressures. Beta-adrenergic effects. These increase heart rate and force of contraction, improving circulation. However, these benefits may come with some drawbacks, such as increased myocardial oxygen consumption and the risk of ectopic ventricular arrhythmias. Potential drawbacks. While adrenaline has significant benefits, it's important to be aware of potential drawbacks. Increased myocardial oxygen consumption can lead to further heart damage. Ectopic ventricular arrhythmias, especially in the presence of acidosis. Transient hypoxemia due to pulmonary arteriovenous shunting. Impaired microcirculation and increased postcardiac arrest myocardial dysfunction. Clinical considerations. Despite these potential drawbacks, adrenaline remains a vital drug in the management of cardiac arrest. Some studies have shown improved short-term survival with adrenaline use. There is no conclusive evidence of long-term benefit, but the documented short-term survival improvements warrant its continued use. Summary. To summarize, adrenaline is a crucial drug in the treatment of cardiac arrest due to its powerful vasoconstrictive and cardiac stimulating properties. Its use is guided by the type of cardiac rhythm and administered without interrupting chest compressions. While it has potential drawbacks, adrenaline's role in improving short-term survival makes it an essential tool in resuscitation efforts.